Are we on? Okay, hello everybody. Hello Africa, hello Asia, Europe, Latin America, North America, and Oceania.
Good morning,
Welcome
Dr.
to the
Belinda. Please put your camera on. We'd love to see your lovely face.
yeah, I thought the camera was on. Oh. Welcome to this enlightening 7th Global Health Pre-Summit webinar on phytomedicine from farm to bedside. We are especially pleased to see so much interest for the discussion of medicinal cannabis and its growing role in modern healthcare. Phytomedicine. What is phytomedicine? Phyto actually originates from a Greek word, which basically means plant. The use of plant compound for medicinal purposes. And it has been in the heart of ethnobotanical healing for centuries. The World Health Organization estimates that 80% of the world population use phytomedicine. The significance of phytomedicine is illustrated by the plant origin of several modern medicines. Take, for instance, morphine, originating from a plant called Papaver somnifera. Aspirin, we all know aspirin. We have used it on our day-to-day inflammation cases. Originates from a plant called Salix alba. Quinine, Cinchona officinalis, that is the plant that produces quinine. Quinine and artemisinin, very, very vital medicine in malaria, especially in malaria-prone areas. It has been used for years. Artemisinin originates from a plant called Artemisia afra or absinthium, depending on the species. And today, we stand at an extraordinary crossroad where science, nature, and innovation meet. And medicinal cannabis or medical cannabis exemplify this energy. The increased globalization and acceptance of cannabis has paved way for new research and therapeutic possibilities. We are now gaining a better understanding of potential of cannabinoids and flavonoids in cannabis to treat various conditions ranging from chronic pain, anxiety, and neurological disorders. This shift is driving a growing acceptance of medical cannabis among healthcare professionals and public, moving towards a holistic, evidence-based approach to harness its medical benefits, while prioritizing efficacy, safety, and accessibility to all. Today, we are truly blessed with a special lineup. We have pioneers in this field who are ready to enlighten us about the therapeutic use of cannabis and how they are changing our today's life. Let's begin by welcoming Dr. Sandra Carrillo, a passionate voice in this space and a leader in cannabis innovation. Dr. Carrillo is a medical doctor, a professor at the University of Colombia, and the president of the Colombian Medical Association of Cannabis Medicine. She is deeply committed to educating others about the therapeutic benefits of cannabinoids. Her work has paved way for safer, smarter use of medical cannabis, not only in Latin America, but even beyond. Welcome, Dr. Sandra Carrillo, and talk to us about the therapeutic benefits of cannabinoids. The floor is yours.
Thank you so much. Good morning, good afternoon, good evening to everybody. They are connecting from different parts of the world. I am very excited to be here today and this amazing academic. I'm gonna share my screen. Now you see my screen?
Yes, we can.
Perfect. So it's a pleasure for me to be once again part of this amazing initiative that is the Global Health Catalyst Summit. This webinar is very important, and I am looking forward to the conferences in Harvard and MIT this upcoming June and September. I've been part of the Global Health Catalyst Summit for already 5 years, and it's amazing that this year is going to be the 10th anniversary, and also feel very honored to be part of the International Phytomedicine Institute. Today, I'm going to be talking, as Dr. Belinga said, about therapeutic applications of cannabinoids. This is going to be a very quick summary of the therapeutic applications of cannabinoids in the clinical practice. This is a little bit about my professional work and disclosures. It's very important, as Dr. Belinga mentioned, to talk about cannabis history. Cannabinoids are being used by ancient civilizations. This was part of ancient medicine. We have records of the use of cannabinoids even 4,000 years before Christ, and cannabis was listed as one of the 50 fundamental herbs in traditional Chinese medicine. It was used by Egyptians, Greeks, Chinese, but it was Dr. William O'Shaughnessy who brought it to the Western civilizations. And it's important to remark that by the 20th century, over 100 papers about cannabis were published in Western medical journals. And we used to have these type of preparations with cannabinoids and cannabis over the counter. Sadly, the prohibition came and the history changed, but the good news is that even though, despite prohibition, a lot of researchers and scientists, they were very intrigued and excited about the potential of the cannabis plant has. The cannabis plant, as you know, is a very complex but a very complete plant that it has around 2,000 compounds. I had the opportunity to be a speaker with Dr. Lumir Hanus. This is a very important scientist that's been researching about this plant for many, many years. We know that the plant has flavonoids, terpenoids, alkaloids, glycoproteins, and of course the phytocannabinoids. The ones that we study more are the CBD and the THC. But there is many others, minor cannabinoids, that they have a huge potential. And it's because we have an endocannabinoid system that the cannabinoids that are coming from the plant, they exert the therapeutic actions in our body. So it's important to know that our endocannabinoid system is composed by the receptors, endocannabinoid receptors. The ones that we are studying more is CB1 and CB2, but there's many other receptors. We have endocannabinoids, as the name says. Endo is our own body produce these ligands, and we have enzymes that degrade and synthesize these endocannabinoids. But there is different types of cannabinoids. The ones that our body produces are endocannabinoids, the phytocannabinoids, they're coming from the plant, and the synthetic cannabinoids. So it's important to know how cannabis works. As you see this graphic, we are talking in this graphic, mainly we see the mechanism of action of CBD. CBD interacts with many targets, and you see in here interacts with serotonin receptors, with TRBP, with ion channels like calcium, also with different interactions with CB1 and CB2 receptors. And this is why we achieve the therapeutic potential of this cannabinoid, particularly in here here we're seeing CBD. But among the therapeutic applications, we see that do all these interactions with receptors and ion channels, we have to watch for the other interactions with other medications and with other treatments. So it's very important as physicians to acknowledge this. And as physicians, when we're going to decide to apply a treatment for a patient, we also need to see the scientific evidence that we have that is backing up that decision making when we say, are we going to do this treatment for the patient? So we see this pyramid of the hierarchy of evidence, where we see in the top of the evidence systematic reviews, and then we see randomized controlled trials. And this is important. Why? Because when I had the opportunity to be professor of many diploma certifications and certifications with university, and when you are in front of a scientific community, a lot of people says, oh, there's not enough evidence. Cannabinoids, cannabis is not enough evidence, and I'm going to show you very quickly today what evidence we have, and that there is a lot of evidence, but this evidence is for particular cases. It's not a one cure fits all, or is not a panacea, but it has very specific indication, and it's a very, very important treatment that every doctor should have in the toolbox. So we have, as you saw in the pyramid of the hierarchy of the scientific evidence, systematic reviews. This systematic review was published in 2017 by the National Academies of Science, Engineering, and Medicine. It was a very valuable consensus where they reviewed more than 20,000 articles, and it was evaluated by a very prestigious committee. So what they were doing is they were evaluating the benefits and the risks of the use of cannabinoid therapies. In this publication in 2017, among of the most important conclusions that they found is that they found conclusive of substantial evidence of the use of cannabinoids for the treatment in chronic pain in adults, as an antiemetic for the treatment of patients with nausea and vomiting induced by chemotherapy, and improving spasticity symptoms in multiple sclerosis. They found moderate evidence improving short-term sleep outcomes in individuals with sleep disturbances with chronic pain. And we see in here limited evidence and no evidence. Let's remember this was published in 2017. That means that they use all the publications that they were before 2017. I have highlighted in here refractory epilepsy in pediatric populations as conclusive of substantial, is because this evidence was published after 2017. And I'm going to walk you through the most important papers or journal publications in very reputable journals, medical journals and scientific journals, that they are proving why these therapeutic applications, that they have conclusives of substantial evidence, so that will give the physicians, the healthcare professionals, that important information. As physicians, we have a premise that says, do not harm. So that's what we need, the scientific evidence to back up the decisions that we make in the clinical practice. There is another documents that they've been publishing all these years as a tool for healthcare professionals. This was published by Healthcare Canada, where there is like important information for healthcare professionals. This was published for the European Monitoring Center for Drug Addiction. This is an important document that it was published, is a systematic review where they were founding where was the scientific evidence for medical benefits of cannabinoids. This was 2020, so 7 years later after they published the one of the Institutes of Science and Engineering. And we see in here pretty much similar of what we see in there. Multiple sclerosis, you see the big circle, a lot of studies, very well done, good quality. We see chronic pain, we see chemotherapy-induced nausea and vomiting, we see epilepsy. This is important because these are systematic reviews. I am comparing these randomized controlled trials, systematic reviews, now with this very interesting concept that is the real world evidence. In this publication of 2021, they were talking about, this was published in the UK, and they were talking about the current controversies in medical cannabis and recent developments in human clinical applications. And the summary of this publication is that there is some conditions where the cannabinoids are used, and they are very well established by now, with very solid evidence, but the conditions have very and relatively small patient numbers. When we're talking about refractory epilepsy, MS, we have very good evidence, and I'm going to show you, but there is conditions where the numbers of patients are higher, the evidence is sometimes not too conclusive, or the quality is not as good as we would like to see it, and this is why in the clinical practice, after all these years, we have a lot of real world evidence. And this paper, I like to bring it to understand that randomized controlled trials and meta-analysis are the gold standards, and we will always look for this type of research. But we cannot dismiss the real world evidence that is another tool. So I'm going to walk you through very quickly, because we don't have too much time, and I want you just to pick the highlights, because we're going to be launching an educational program where you're going to be able to see all these subjects in detail. But for example, therapeutic applications in refractory epilepsy, we see publications in here at the New England Journal of Medicine and JAMA Neurology, Frontiers of Neurology, and these, as you see, are randomized placebo-controlled trials talking about the use of cannabinoids in most of these studies, particularly CBD, cannabidiol. And actually, the only product that it has FDA approval is this Epidiolex, that is cannabidiol, for the use of refractory epilepsies in children more than 2 years old, particularly in syndrome of Lennox-Gastaut, Dravet, and tuberous sclerosis. Now we move to therapeutic applications in multiple sclerosis. We see in here systematic review or reviews. So for those that say, oh, there is not enough evidence, imagine we have systematic review and reviews where they show that cannabinoids are very useful for patients that have spasticity and multiple sclerosis. And we have different types. Even I have this paper in here that it was published in 2005, but we have papers that they were published recently, and we have on the left the evidence mapping of cannabis uses in multiple sclerosis, and as you see in the graphic, probably beneficial, and you see the circles. The circles shows you the amount of patients that they were in these studies. We see in here in the green 2,138 patients. The study was about cannabinoids versus placebo and spasticity. Now we move to applications and nausea and vomiting induced by chemotherapy. Also, we have a lot of different levels of evidence, but we have, again, randomized controlled trials, and that it shows us the use of cannabinoids in cancer, particularly in nausea and vomiting. Now we move to applications in cancer-related pain. Again, we have in here this systematic review where they show this mapping where all the majority of the studies have done regarding to uses of cannabinoids in cancer-related pain. And we see one large study where it says probably beneficial on the right in pink, that it was 1,400 patients using cannabinoids versus antiemetics in nausea and vomiting induced by chemotherapy. Also, we see groups of studies with 400 patients talking about the use of cannabinoids in chronic pain, cancer-related pain. And on the left, we see published in the Journal of Pain and Symptom Management, multicentric, double-blind, randomized, placebo control, talking about the use of cannabinoids in intractable cancer pain. So yes, there is evidence. We need more evidence, of course. It's important to have more evidence always, but it is important to see the amount of evidence that we have in here. Sometimes when they do the Cochrane assessments and they do the reviews, when they disestimate some studies and they say that they don't have the study wasn't well conducted, or they have some risk of bias. Usually is because, for example, in cancer or in nausea and vomiting induced by chemotherapy, sometimes they were saying that the study wasn't significant because they didn't talk about what type of chemotherapy they were giving to the patient. So they were grading the study as low quality for questions that they weren't assessed in a proper manner. But when we see there is a very growing interest and keep doing research regarding cannabinoids in cancer-related pain. Now we move to therapeutic applications in chronic pain. There is a lot of publications. I want to bring just a few ones. There is a lot of scientific evidence regarding the use of cannabinoids and chronic neuropathic pain. And it is such a good evidence that even the Canadian Pain Society a few years ago, like long time ago, issued a statement saying that they were moving cannabinoids from the fourth line agents to the third line agents. And I put in here the publication. And actually last year, 2024, there were published clinical practice guidelines for cannabis and cannabinoids-based medicine in the management of chronic pain and co-occurring conditions with some clinical practice guidelines that there can be very useful for students or for people that want to learn about this subject. And again, we have in here, I found this a very valuable tool, the evidence mapping and appraisal of systematic reviews. As you see on the left, they have the AMSTAR, that is a very important tool for the systematic reviews. And you see in here the cannabis uses in pain. We see on the probably beneficial a number of 2,600 patients with a big yellow circle using cannabis and cannabinoids versus placebo in chronic pain. So we do have evidence, and as you know, all of you know, is the opioid crisis, and the cannabinoid use in it has an opioid sparing effect, and this is a very important tool right now when we're managing chronic pain of different etiologies, palliative care patients with chronic pain due to cancer. And we have different publications in here on the left, a systematic review that talks about the reduction of opioid dosage in the treatment of non-cancer chronic pain. And the results are 9 studies involving 7,200 patients were included. And there was a 64% reduction in opioid dosage when used in combination with medical cannabis. And on the right, we see the clinical practice guidelines in 2024. They even give to the students or to the people that is curious about this, so a suggested approach for adjunct cannabinoid use for opioid sparing. So as I walk you through the evidence that we have with the pathology, is a solid evidence, as I mentioned and show you. We have meta-analysis, systematic review, randomized placebo control. So when somebody asks you and tells you, oh, there is not enough evidence, we have a lot of evidence for these pathologies. Now, talking about sleep. This systematic review was published in 2022, where they did an important search, and they identified 4,500 studies, and they found that the sleep improved with patients that have pain-related disorders. So I'm not going to stop in this study, but we have a systematic review regarding to the use of cannabinoids for sleeping problems. So there is a big body of evidence that is being published every day. I'm very excited because every day when I wake up, I see new publication, better studies, more curiosity in the scientific world about learning all these other questions. And you see here more publications, more scientific evidence. And this is a last one that I saw recently, that it was published in 2024, where they exploring even, and they are gathering the evidence of other therapeutic applications and future applications. So I think the future is very bright regarding to research, but we need more funding for research projects and clinical trials, more research and development, more control and replicable studies. We need to unlock the secrets of minor cannabinoids. They've been doing amazing research in United States, in Israel, in Canada, even in Latin America. There's a very interesting amount of research being done. We need to discover new medical applications, because we already have established these applications that I show you. They have substantial evidence, but we need to find more. We need to advance the regulation to enable research. We need to do pharmacogenomics. This is the new trend, and it's not just a trend. It's very useful to use pharmacogenomics, and we need to keep doing all these because of the patients. As a physician, we owe the patient to give them better medicine with less side effects, improving the quality of life. And I want to appreciate to one of my most important mentors that I have, and is Professor Rafael Meshulam, that gave us so much knowledge. And I want to say thank you to Dr. Will Ngwa and to the Global Health Catalyst and the International Phytomedicine Institute for gathering all these professionals. And I invite you to stay tuned, because we're going to be launching a very important educational program, and also to attend the Harvard MIT summits in June and in September. Thank you very much.
Dr. Carrillo, wasn't that mind-boggling? Oh, that was so insightful. Very, very insightful. I see Dr. Greenspoon has not joined us as yet, but that session, I love the fact that you brought the pharmacogenomic aspect of it. You know, in the past, most drug production trials were conducted in a limited gene pool. But now that you've brought the aspect of pharmacogenomics, we want to spread that all over the world and see how our genes will respond to cannabinoids for the therapeutic use for all. Thank you so much. And thank you, because you have touched on, what can we say? You have answered the question that most of us ask ourselves. Where can we say medical cannabis work today? And you've gone so intensively and extensively into it to tell us the evidence that is out there. But some questions are still lingering in people's mind. And one of it's about addiction, about do we have evidence of addiction or later addiction? And if so, how are we tackling that?
Yeah, that's a very important question. And in the clinical practice, and actually the American College of Physicians in 2020 issued a recommendation for physicians asking to do periodic screening of what we call now cannabis use disorder. But this is due to the increase of the concentrations and the hybridization of the plants of cannabis. Let's remember that 20 years ago, the highest concentration of THC that we could find in a plant was 4%. But now they are doing hybridization of the plant, and they're getting even 20, 30%. So what the American College of Physicians says that they're increasing more visits to emergency room, but this is more due to the use of, I call it non-medical cannabinoid use. They used to call it recreational. I don't like that word. We should call non-medical. And let's remember, in non-medical, they use indiscriminated amounts of THC, and it's the THC, the molecule that can cause the cannabis use disorder, for saying that. In the therapeutic context, when we're using it with a patient in an environment where we are seeing the patient in the consultation, we always start with small doses. We do a titration and we assess when the patient is going to have some side effects. Immediately what we do is we start reducing doses. But so usually in the therapeutical or in the medical use stage or scenario, is very rare to develop cannabis use disorder. But in medicine, I learned that you never say never. So we have to remain aware about this and do this screening. They even have a tool that we have in our consultorios, in our offices, to assess this risk. But the cannabis use disorder is mainly, what they call addiction, appears on the users of cannabinoids, particularly THC, on the recreational, and again, I said I like the word recreational, I would say non-medical scenarios. So I hope I responded the question.
Dr. Berlinga, you're muted.
Sorry about that. The THC content is the one that is bringing all the addiction. So, and that is what also brings addiction to the non-medical or non-medicinal uses. We don't want to call it recreational, as Dr. Carrillo has said it. We are talking about the medical part aspect of it. One of our panelists one of our viewers want to know more about, he wants you to discuss further on researching cannabis on epilepsy. Can you elaborate just further on that, Dr. Carrillo, please?
Sure. I think the use of cannabis or cannabinoids in epilepsy, as I mentioned and I showed you, we have publication in the New England Journal of Medicine, JAMA Neurology, Frontiers in Neurology. So there is plenty of research, and they've been publishing some studies about long-term, and in this case, it's usually the patients treated with the FDA-approved molecule that is the Epidiolex, that is a purified form of CBD. And what we see, and the colleagues, neurologists all over the world, and I love this, is that the word is being spread, and it's not like nobody is preaching it. It's just the studies in there, the evidence in there, the medical journals, and there is a lot of patients being treated right now with cannabidiol, and so the evidence is growing. There is a few long-term studies that are being published regarding to safety and efficacy, and I think that there is still a lot of questions that we need to do, because in research we always need to look further and also do pharmacovigilance, because my biggest concern in this is that we know Epidiolex is the molecule that is being approved by FDA, but some people say, oh, Epidiolex is CBD, so I'm going to go and buy in the gas station the CBD that they're selling, and there is a lot of mislabeling and misinformation. So the patients are at risk when they're buying a product that we don't know. We need to see the COAs, but no longer the COAs. I rely on them because sometimes there's a lot of fake COAs, that they download the COAs from the internet and they put it in a label. So we have to be very careful because this is not a hype, this is a treatment, and cannabis is medicine, and we have to treat it as medicine, and we give the respect that the medicine deserves. It's beautiful that it's coming from a plant, but as you said, Dr. Belinga, other medications that we use regularly are coming from plants. So it doesn't mean that it's innocuous. Of course, it has side effects and drug-drug interactions, but the beauty of this is that it's a very noble, for example, the CBD is a very noble molecule, but it has a lot of interactions, as I showed you in the graphic, and those interactions are not a reason to be afraid, are a reason to study. Where are the interactions? If the healthcare professional knows the interaction, the patient will be safe. So, because they are not contraindications.
Great. Another question, what is the biggest barrier when it comes to proper integration of cannabis in healthcare?
I love that question. I just published an article in a journal talking about the barriers of prescription. Particularly, I did it in prescription in Colombia, and I think that the barriers are the same all over the world. I think, first of all, is the lack of education, because again, let's say this is medical cannabis, needs to be prescribed by a physician. In some countries, just a physician is allowed to prescribe. In other countries, they just recommend. In United States, is recommendation. So if the healthcare professionals, they don't learn about the endocannabinoid system, about the therapeutic applications, the access for the patients is not going to exist. So the patients are going to be just running around, buying in here, buying in there, self-medicating, and that can be in the future, if it's not already a problem, public health problem. Because so first, for me, the first barrier is the lack of education. That's why I am so excited about launching this educational platform with the Global Health Catalyst and with the International Phytomedicine Institute. The second is access for the patients for costs. We need the healthcare system to cover the costs, because truth to be told is not everybody can afford $100 or $150 a month to pay for this medicine. Is beautiful and it works very well under the accurate prescription and recommendation, but it has a cost. So that's another barrier. And another one, we need more research, of course, and it's an over-regulated industry, over-regulated. So I do think that I will summarize in these three pillars: education, accessibility for the patient, and the organize the regulations, to move forward with the regulations, because all over the world is over-regulated. So we have to find like a middle point with regulations are good, but over-regulations are not that good. So I think that's a little summary there.
Education. Simon wants to know more. It is well known that cannabis induces psychosis, but in your presentation, cannabis instead treats psychosis. Could you throw more light on this, please?
That's a great question, because, and I invite my students when I'm teaching in universities, or I always says, remember, I told you at the beginning, cannabis is a huge word. Professor Lumir Hanous is the scientist that studied a lot this plant, and he told me they isolated more than 1,500 molecules in the cannabis plant. And I think there is already like 140 cannabinoids that they isolated. So when we talk about cannabis, no, we're talking about, in psychosis or schizophrenia, we're talking about THC. So THC is the molecule that I will say is the only contraindication. Don't use THC in patients that have psychosis or schizophrenia or a family history of these mental health problems. But there is ongoing research right now. We don't have still the systematic reviews and all this, as you see the pyramid of the hierarchy of the evidence, we still don't have the quality of evidence to say the CBD will treat psychosis, but there is ongoing research all over the world where they're using CBD to treat some patients with psychosis. Again, I'm not saying, oh, just go now and treat a patient with psychosis with CBD, because as physicians and doctors and healthcare practitioners, we need the scientific evidence to know that we're doing a treatment that is going to benefit the patient. So yes, the question is, there is this distinction. THC is the one that can cause the psychosis and that you cannot use when patients have schizophrenia, but CBD and the other side is being studied just in early stages, very early stages to treat psychosis.
Good, great and great. Another question. There's mixed evidence on cannabis about strain and dosage. Why and how can this be addressed?
Let me try to see the question. I didn't. Can you please repeat the questions? I'm sorry.
There's mixed evidence on cannabis about strain and dosage. Why is that and how can it be combated?
Well, as I show you, that there is some protocols and guidelines in different countries. For example, Australia, they have like a clinical protocols and guidelines, and there is some guidelines that they've been published in United States, as I showed you earlier. Definitely, the dosing with cannabinoids is, I will say, an art, because we need to do a very individualized approach. And when we were talking about pharmacogenomics, this is very important too, because not all the patients, they respond the same to cannabinoids. So I think we have to keep building more and more dosing protocols and not just with CBD, THC. When the research start showing about the huge potential of another cannabinoids, we will be able to unleash the power of other cannabinoids that I am very excited. But definitely we need to have more protocols, because in medicine and in hospitals, everything is about protocols. But with cannabinoids, since it's like a very personalized medicine, you have to have the patient in front and assess all the circumstances around the patient. And even now, the pharmacogenomic is very important.
Great. Another question
Dr.
from
Belinga,
Chris.
could you please check
Yes.
if Dr. Greenspoon is on?
Okay, let me check.
Sorry to interrupt. I just don't want to miss him.
I just spoke to him. He said that he has having issues having the link, so he's struggling entering the panel. Yeah,
So
apologize.
Dr. Greenspoon, are you there? No, I don't see.
No, he's not in.
He's not here.
He
He's
just
not in
emailed me
yet.
that he's having issues with connecting to the link, and he apologized.
Okay. Apologies. Once he comes in, we'll try and put him in. Then another question, just I see we are also, time is not on our side. How can patients safely use medical cannabis against epilepsy while managing interaction with other medication they may be taking? Drug interaction.
Very important. And that slide that I showed you, where the CBD has I don't know, I think they were like 20, 30 therapeutic targets that CBD touches. This question is very important, because particularly in epilepsy, and is being documented the interaction, for example, with clobazam with valproic acid, that these are medications that very commonly the patient takes. So as I said, it's not a contraindication, and the studies they've been done when the patient is taking clobazam, for example, what happens is due to that drug-drug interaction that we know that both medications are metabolized through the CYP450 in the liver. So what happens is that it increase the levels of one of the other medication. In this case, when we give CBD concomitantly with clobazam, what happens is that increase the metabolite of the clobazam, that is the N-desmethylclobazam, and the patients start experience side effects like somnolence and other side effects. So it's in here where I said titration and dosing is an art. I mean, and medicine in general is an art, but based in science and evidence and in research. So what happened in here is not because of the patient is taking clobazam, cannot take CBD. What happens is, usually what I do is I work with the multidisciplinary group. I always, because let's remember, the indication is refractory epilepsy. What refractory epilepsy is? A patient that is already taking 2 or 3 medication and it hasn't worked. So of course, the patient is going to have other medications. So what we do is we work with the neurologist, that is the doctor that has been treating this patient since the very beginning. We cannot just come and jump and say, okay, forget about your neurologist. I'm going to do this. I'm going to take this medication. No, we work together. And this is on behalf of the patient because it's better for the patient. So what happened in these cases, and the studies have shown this, is you reduce the doses of the clobazam, and that way the patient will obtain the benefits from the clobazam and from the cannabidiol. And it's also to measure levels of clobazam to see when the patient is reaching that level that is not good. So what we do is monitorization. This is what I said. Cannabinoid medicine and the consultation is very personalized, and this is like my personal anecdote that I used to work for the healthcare system, and I had to see before a patient every 18 minutes. It's impossible to see one patient every 18 minutes, like 4 patients in 1 hour. But now, when since 5-7 years ago that I've been doing cannabinoid consultation, among other consultations, I have to take like 1 hour to see when I'm seeing a patient for first time. And then after that, I see my patient, I talk to my patient like every, when there's the titration process, like every 3 or 4 days. And then according of the status of the titration and the dosification, you have to keep constant communication for the patients to assess exactly like this, as the person was asking about interaction. For example, with clobazam, the mother tells me, oh, since we're giving CBD, the patient is more somnolent, it has to be in bed, don't want to do anything else. So then we do like, we measure the clobazam. So it is a very personalized medicine, and it's through the monitorization of the patient that we can avoid these things happen. Also with the valproic acid, that is a very common medication these patients come. We have to measure the transaminases, the liver impairment. Sometimes, and the studies are proving this, there is an elevation of transaminases in some patients that they're taking valproic acid. And what that means, it doesn't mean that you cannot give them the valproic acid. It means that you have to do a baseline lab test of liver function, and then 3 months later, and then 6 months later. Is about, again, personalized medicine and monitorization. So yes, there is a lot of drug-drug interactions because cannabinoids are metabolized through the liver, and a big majority of the medications we take every day are metabolized through the liver, but that doesn't mean that we cannot use them together.
Oh, great, great, great. You see, this is a very wide topic. So for you to get more insight on drug interaction of cannabis with other medication, join us, enroll in the cannabis class in the International Phytomedicine Institute that will start from the 17th of May. So yeah, you'll get more insight from there. Before I even talk more about that,
Dr.
let us
Greenspan,
answer the last question. What is
Dr.
the attitude of pharmaceuticals companies to the scientific research and evidence of benefits of cannabis products for our health?
Well, surprisingly, of what everybody thinks, very large pharmaceutical cannabis are having divisions of cannabinoid research right now because they see that there is evidence and there is a huge potential. So it's very interesting.
Just a minute, is Dr. Greenspoon in? Dr. Greenspoon?
Yes, Dr. Greenspoon is among one of the attendees. He's just mentioned he's not able to go on. I think he's one of
I need
that have my
him to please comment in the chat so I can identify him.
Will Dr. Greenspoon comment in the chat? Thank you.
Yes, so you will make him a host. I think happened the same to me.
Yes, as soon as I recognize, because it's not his name.
Greenspoon, can you change your name on the chat? As we wait for Dr. Greenspoon, we shall be having, as I say, a cannabis, kind of a course on cannabis, medical cannabis, starting on the 17th of May at the Global Oncology University, which is an international Phytomedicine Institute, which is a global oncology university branch. We want you to enroll you see there's so much to learn about cannabis. It's a wide topic. Learn about its efficacy, learn about its safety, learn about its drug interaction. We welcome you, health practitioners, if you want to, and there's gonna be a certificate offered for this. For those who, the enrollment is free, and if you want a certificate, you'll have to pay some small amount for it. Visit our website, Global Health Catch List, for more information. Can we access Dr. Good, Dr. Greenspoon. Welcome,
Hi,
welcome.
can you guys hear me?
Yes, we can hear you.
All right, first of all, it's my birthday today. I'm 59. Second of all, I had a really hard time logging on, so I'm sorry that I'm late, and it distracted me a little bit from hearing you guys because I was frantically trying to log on. But I'm very, very happy to be here, and I'm honored to be with you guys on this panel.
Okay, our time is almost over. Can you tell us briefly about let me introduce Dr. Greenspoon just a little bit so that you know who he is. Dr. Greenspoon is a medical doctor and also a lecturer at the Harvard Medical School. He's a cannabis specialist. He has written this amazing book about cannabis, Seeing Through the Smoke. It clears the myth and presents facts about cannabis. Dr. Greenspoon, can you briefly just tell us about your journey in cannabis in brief, because our time is almost up?
Absolutely. My father, Dr. Lester Grinspoon, was a very legendary cannabis expert. In 1971, he published a book called Marijuana Reconsidered and called for legalization at a time when only 12% of Americans were in favor of legalization. So I grew up with medical cannabis. My brother Danny unfortunately died when I was 8 years old. He was 16 years old from leukemia. My parents illegally got him cannabis to smoke, and it really helped him eat and to maintain his weight in the last year of his life. So I grew up associating the smell of medical cannabis with healing and with improved health, as opposed to being susceptible to all the nonsense they provide you in medical school. I've been treating people with medical cannabis for about 25 years with a lot of success. I also treat people for cannabis addiction and for cannabis allergy and for other problems with cannabis. And with my book, which you generously mentioned, Seeing Through the Smoke, I really go over the social history, the harms, the real harms, which cannabis proponents need to understand, and then the harms that were sort of these magnifications of the war on drugs. Then I talk about the benefits, which the prohibitionists have to acknowledge. and the benefits that are true, and the benefits that are sort of like not particularly true, like cannabis cures cancer, that can be very misleading. And then I actually talk about how it improves people's lifestyle, it helps people who are aging, provides insight and so forth. So I try to go over the whole history from my vantage point of having been involved with it for 25 years. Most recently, I'm now working at my hospital, at Mass General Hospital, at the addiction clinic, and I'm really interested in how cannabis can help people as an exit off of opiate addiction and other addictions, as opposed to, the gateway theory that we've been exposed to. So that is me in a nutshell. So.
Oh, thank you so much. Thank you so much for you to hear more from Dr. Greenspoon and Dr. Carrillo and other educators who are renowned educators from all over the world. Enroll into our cannabis course again, starting on the 17th of May. Don't miss out to listen to this insightful speakers. They'll teach you more on what we need to do, how we need to go, how we need to harmonize the use of cannabis globally. Thank you so much, Dr. Carrillo, for your insightful knowledge about medical cannabis. Dr. Greenspoon, sorry for the technical hiccup that you encountered, but thank you so much for joining us in the end and for taking us through a glimpse of your book and seeing through the smoke. And for us to know more, please join us. Thank you so much for our viewers. And let us meet again. We have also come to our Global Health Summit on the 7th. For those who can't not be there physically, please enroll to join us remotely. Go to our Global Health Catalyst website for more details. Thank you so much and goodbye.
Thank you.
Thank you. Happy birthday.
Thank you.
Bye.
On the 17th, I will be able to I'm going to log on at 2 in.the morning to make sure I can actually avoid the technical difficulties. So.
Yeah.
Thank
Okay.
you.
See you
Happy
there.
birthday,
Bye.
Dr. Greenspoon.
Thank you. And thank you guys. Again, sorry that I was